On the screen, D. We all ready to roll? Awesome. Okay, good morning, everybody. Welcome to Grand Rounds. I think this is our second Grand Rounds of the back in Grand Round season. I'll turn the podium over to Dr. Shapiro in just a moment. Just a couple quick first announcements. First of all, from the educational program perspective, we have our second open house for virtual open house for our applicants and med students from all across the country. It was very well attended last month, and so certainly to invite our residents and our faculty to take part of that this evening. If any questions about that or accessing the WebEx, please shoot an email to Anna or Dee. Appreciate that. One other thing too, just as the rest of the team's coming in, this has been an odd week emotionally for, I think, our area and certainly within our department. Tragic deaths of UW providers, what's going on in our area with COVID. It's just continues to be a strange, stressful time all around. There was a nice email from the UW leadership, and just want to reiterate that there are a lot of resources for all of us, whether we're students, residents, faculty, to make use of if things are getting tough. It's out there. It's normal to have emotions about everything going on right now. I just want to reiterate that to the group about resources, and please let us know, reach out to each other for those if there are any questions. With that being said, it's a pleasure to introduce Dr. Shapiro. Dan is, I believe, are you in your 8th year of residency right now? Oh, no, sorry, that's right. You did actually finish our training program and do a fellowships, and we've welcomed him back. So Dan did his medical school and residency training here at UW, took a little respite down in Texas at the MD Anderson Cancer Center, and has returned as an assistant professor on the CHS track with a specialty focus in urologic oncology, and is going to be presenting to us today about non-invasive bladder cancer. The floor is yours, Dan. Thank you.
Turn it on, Dan.
Can you hear me now? Is that better?
Oh, yeah.
Okay. All right, great. So today, as Dr. Williams said, I'll be discussing non-muscle invasive bladder cancer. For some of the objectives of this talk, we'll briefly discuss bladder cancer epidemiology and risk factors. We'll go over the natural history of non-muscle invasive bladder cancer, and then move into risk stratification of the disease, the optimal way to diagnose, and then manage non-muscle invasive bladder cancer, and then finish off with how we survey these patients. So in terms of bladder cancer epidemiology, bladder cancer is more commonly diagnosed in developed nations. In the US, bladder cancer is the 6th most common cancer, leading to about 81,000 new cases and 17,000 deaths. It disproportionately affects men at a 3-to-1 male to female ratio. And in terms of presentation, as any urologist knows, the vast majority of the patients that we diagnose present with hematuria, usually macroscopic or gross hematuria in about 78% versus microscopic is in about 14% of cases. And the median age at diagnosis is about 73 years old. Most of the patients who are diagnosed with bladder cancer will present with clinically localized disease. Only about 5% of cases or 5% of patients will present with metastatic disease, and compare that to something like renal cell carcinoma, where about 1/3 of the patients will present with metastatic disease, which is good news because for the patients that do present with metastatic disease, the 5-year survival rate is pretty dismal, only about 7%. Compared to localized disease or non-muscle invasive disease with a improved 70% 5-year survival. In terms of the stage and grade at presentation, most of the patients present with TA or T1 disease, and among those, TA low-grade disease is the most common presentation among bladder cancer patients. If we look at the risk factors for bladder cancer have been pretty extensively studied. There are some genetic predisposition syndromes, and also there are familial associations with bladder cancer, so it's important to get a good family history. Patients with a family history of bladder cancer have about a 2-fold increased risk of bladder cancer. As we all know, tobacco smoking is by far the strongest risk factor associated with bladder cancer, and current smokers have about a threefold increase in their odds of developing bladder cancer. There are also environmental risk factors such as aromatic amines, arsenic, and patients who have chronic infections can develop bladder cancer. And there have been some associations with obesity being associated with an increased risk of developing bladder cancer. And then also certain drugs for the residents, so these drugs often get tested on. Chemotherapy such as cyclophosphamide is often associated with bladder cancer. Also, there's some loose associations with a diabetic oral agent, pioglitazone. And then lastly, socioeconomic status has been associated with bladder cancer, including an increased risk among patients who have low education. And also the outcomes for patients who have low socioeconomic status tend to be worse. So to delve into smoking and bladder cancer, smoking is a strong independent risk factor for bladder cancer development. Both the intensity of the smoking or the number of cigarettes per day and also the duration of smoking both impact the risk of bladder cancer development. If you look at the number of years of smoking, regardless of the amount, there's a nearly linear time-dependent association. And then smoking cessation will reduce the risk of bladder cancer, but this is really dependent on the time since the patient quit. If you look at the graph down on the bottom right there, it takes over 20 years to really reduce your risk down to the nadir levels, and your risk really never returns to the baseline population. And there have been a lot of studies on improving smoking cessation, and one study surveyed smokers with a diagnosis of bladder cancer and found that a few factors may aid in smoking cessation, and one of those was actually a bladder cancer diagnosis and using that as a teachable moment. So bladder cancer diagnosis was cited as an independent predictive factor for smoking cessation in many of the patients who were actually able to successfully quit. And also it appears that people are more successful if they quit very soon or immediately after their initial diagnosis, again, supporting our ability to use the diagnosis of bladder cancer as a teachable moment in the clinic and suggesting that they smoke at the time of their diagnosis. And interestingly, in this study, counseling and medication intervention, counseling just specifically on smoking cessation, not using bladder cancer as the teachable moment, counseling and medication intervention didn't appear to be predictive of successful cessation. So when we diagnose patients with bladder cancer who are smokers, it's important that we try and use that moment as a time to try and convince them to quit smoking. So moving into the natural history of non-muscle invasive disease, it's a very heterogeneous disease. So it's difficult to really pull out from the literature what the exact natural history is. There's a wide range of survival outcomes depending on multiple factors. Low-grade non-muscle invasive disease tends to have excellent outcomes with over 90% 10-year cancer-specific survival rates. Compare this to high-grade non-muscle invasive disease, which tends to have 10-year survival rate of about 75%. Recurrence is obviously much higher for high-grade tumors as well. Depending on the study and the use of intravesical therapy, the recurrence rates for high-grade disease can range from 50 to 90%. Low-grade disease has about a 50% recurrence rate with just TUR alone. And then in terms of progression, TA low-grade disease has low progression rates of only 3% to muscle-invasive disease compared to high-grade disease, which can be as high as 50% depending on the use of modern BCG interventions and then how TURBT is administered. So what are our goals of therapy for non-muscle invasive disease? In my mind, they're to prevent cancer-related mortality. We want to prevent stage and grade progression, and we also want to prevent recurrences, but at the same time, we also want to reduce the amount of overtreatment of this disease. So what happens if we just treated non-muscle invasive disease with TURBT alone? So this is an older study, but that is somewhat useful because there's less heterogeneity in what types of treatments the patients received in this study. So it gives us a little cleaner understanding of what happens to these patients. So this was a retrospective series consisting of about 1,500 patients that were treated with TURBT alone from 1968 to 1996. And only 32% of these patients received intravesical therapy. And they demonstrated no progression or mortality among patients with low-risk disease, so low-grade TA. And with increasing grade and stage, there was an increase as expected with progression and mortality. So for low-risk disease, TURBT alone appeared to be successful at preventing progression and mortality. So with that in mind, for low-grade disease, it's important that we stratify these patients, low-grade versus high-grade, et cetera. So I wanted to move into sort of how do we determine the risk stratification, because it's critically important that we risk stratify how we treat non-muscle invasive disease, because the outcomes are extremely different depending on the stage and the grade of the tumor. So some initial attempts were made at risk stratification. These are the EORTC and the Cato systems. The EORTC nomogram was published in 2006. It was based on a series of 2,500 patients from 7 randomized controlled trials that ranged between 1979 and 1989. So an older cohort of patients. Only 4% of the patients in the stratification system had CIS, and less than 10% received any sort of post-operative chemotherapy, and only 7% received BCG, and no one received any maintenance therapy, and also they didn't use re-TUR, so it wasn't a very modern treatment modality system. So if we're comparing the patients today where we use more modern treatment modalities, it doesn't apply as well. And then the Cato nomogram was based on about 1,000 patients from 4 trials for patients receiving BCG on a non-modern treatment regimen and maintenance schedule. So basically weekly times 6 and then biweekly times 2. So again, neither of these systems really are useful for our more modern regimens. And so if you compare it to our more modern patients, this was a retrospective analysis of about 4,700 patients, and the discriminative ability of both the EORTC and Cato nomograms was demonstrated to be pretty poor. If you look at the C indices for the more modern regimen or more modern patient cohort, the C indices were not very strong, only about 0.59 and 0.6. So the discriminative ability of both of these nomograms was demonstrated to be pretty poor among patients treated with modern BCG therapy. And these models both consistently overestimated the risk of progression and recurrence. So if you're using these models today, patients may experience overtreatment. So given the nature of the EORTC and Cato nomograms, the AUA guidelines came up with their own nomogram, and this was based solely on opinion and wasn't validated when it was initially proposed in 2016. And 2 novel areas of inclusion for this nomogram was inclusion of small TA high-grade lesions in intermediate risk patients and the consideration of BCG failure for high-risk patients. And BCG failure was defined as persistent or recurrent disease at 6 months following BCG therapy. So with that in mind, the AUA nomogram was eventually validated in a retrospective patient analysis. Rich et al. In 2020 performed a retrospective review of 398 patients treated over 16 years. 92% of the patients did receive BCG and 46% had maintenance, so a more modern type of treatment regimen. The median follow-up was 3 years. Only about 1.2% of patients died from disease, and it was able to validate that each risk group using the AUA criteria was separated from each other, and the C indices from each group was similar to the EORTC and Cato nomogram, which was kind of interesting. But basically, this was able to validate the AUA nomogram. One major issue that I think about is what do we do with these high-grade tumors that are TA? Is a small high-grade TA lesion really different from multifocal high-grade TA lesion or a large high-grade TA lesion? And current iterations of the EAU and AUA guidelines allow for certain high-grade TA lesions to fall within the intermediate risk category. And so that impacts what treatment you're going to give these patients, because the intermediate, you could consider either intravesical chemo or BCG, but they haven't really been specifically studied with appropriate BCG therapy, and the outcomes aren't very well understood. So this was just recently published. This is a retrospective study from MD Anderson, and they evaluated patients who received adequate BCG induction and at least 2 additional maintenance therapy doses. And they stratified patients based on that EAU risk stratification. And they found that patients with intermediate risk high-grade TA tumors had oncologic behavior that was in alignment with high-risk TA tumors. So the authors concluded that really all high-grade TA tumors should be considered high risk, and they should be considered with BCG therapy. So that's something to consider with these patients who kind of fall in that high-grade TA intermediate risk location. So the bottom line on risk stratification is that it's clearly useful for stratifying patient outcomes and delivering appropriate therapy. There are caveats to that, though. Most of our nomograms don't account for the current standards of care because many were based on large retrospective series with an old cohort of patients. So things like modern BCG regimens, post-op chemotherapy installation, enhanced TUR, that none of those things are often taken into account. And also, many of our nomograms often over-prognosticate recurrence and progression. So continued efforts are being made into better risk stratification models. And just for residents and in-service purposes, AUA guidelines do recommend risk stratification at each TURBT. So talking about our initial diagnosis and performing your TURBT, it's really critical to perform a high-quality TURBT with the goal of a complete visual resection of all tumors. And also documentation is critical, including the following list of location, papillary sessile appearance, size, number, and also findings on a bimanual exam is important. And so in all of my procedure notes when I do a TURBT, I have this checklist in every note. And this is also recommended by the AUA guidelines. Incomplete TURs are associated with higher rates of recurrence and also persistent disease, obviously, at 3 months. So it's important to try and perform a totally complete TUR at the initial TURBT. And also, including detrusor in the specimen is another marker of quality. Some people will even separate out their deeper resection when they send it to pathology to make sure that it's looked for. I don't personally do this because our pathologists are pretty good at finding detrusor, but it is associated with increased risk of recurrence at 3 months if you don't have detrusor in the specimen. And so for patients that didn't have detrusor in the specimen, there's about a 45% risk of recurrence at 3 months versus only 20% in patients who did have detrusor present. And in a review of nearly 300 TURBTs, the use of a standardized approach and surgical checklist were associated with improved recurrence-free survival, and that was independent of other known risk factors of recurrence. So it suggests that in order to really maximize your recurrence-free survival, standardization of your approach and also documentation are important for your TURBT. So moving on, talking about enhanced cystoscopy during TURBT, does that improve our resection? So the AUA guidelines do suggest that we should offer blue light cystoscopy if available, due to its ability to increase detection and disease recurrence. In a patient with non-muscle invasive disease, you can also use narrowband imaging to increase the detection and decrease recurrence, but there's less robust evidence associated with the narrowband imaging, and the stronger evidence comes from blue light cystoscopy. So blue light cystoscopy relies on the absorption of hexaminolevulinate, which is preferentially absorbed into tumor cells, basically a 10-fold increased absorption in tumor cells compared to benign urothelium. The installation is associated with rare but present adverse events. About 2 to 3% of patients can have an adverse event, and there's a slight risk of an anaphylactoid adverse event risk. The sensitivity for detection for CIS in particular is very high, 95%. And the specificity, though, is not as great, about 48%. And so this data presented here is basically raw patient data from a meta-analysis of blue light cystoscopy. And they used data only from prospective trials, and they included 9 studies, about 2,200 total patients. And additional tumor detection over white light cystoscopy was found for all grade tumors, including TA, T1, and CIS. Also, blue light is associated with a lower recurrence rate at 12 months of about 35% versus 45%, which was statistically significant. And that was true in all subgroups of non-muscle invasive disease. And other studies published since then, since this meta-analysis, have demonstrated improved outcomes, including 18-month recurrence-free survival rates of about 18% versus almost 50%. For patients that didn't receive blue light cystoscopy. So there does appear to be pretty strong evidence that blue light cystoscopy improves your detection rate of all types of tumors and may be able to reduce the recurrence rates. So when should we use it? There was a consensus recommendation on blue light cystoscopy published by this group in Nature Reviews in 2019. And you can see the recommendations that the panel made were pretty broad. So they basically said at initial TURBT for non-muscle invasive disease, for patients who have positive cytology but a negative white light, for patients who have intermediate risk multifocal tumors, also for assessing disease recurrence, and also following BCG installation. So basically they said you can use it pretty much anywhere. For me personally, I think it really helps if you have a positive cytology but a negative white light. In that situation, I'm concerned that maybe there's a CIS lesion that I'm not detecting. Also, for patients who have a known history of CIS, I think it's useful. And, at initial TURBT, I think it kind of depends on the situation. If you have kind of a low-grade appearing single lesion, I don't think it's as useful, but it can be used for all of these different situations. So now, after you've performed your TURBT, the next thing that you need to consider is whether or not to give a single immediate dose of intravesical chemotherapy after your TURBT. So the AUA guidelines recommend giving a dose of intravesical chemotherapy within 24 hours of TURBT. If you suspect a low-grade or intermediate risk non-muscle invasive disease. That came from a 2004 meta-analysis that looked at the installation of multiple different agents, mitomycin C, epirubicin, purorubicin, and thiotepa. And they found that all of them were able to reduce the risk of recurrence after TURBT, with a number needed to treat of about 8 patients to reduce 1 recurrence. And for all patients, the 5-year recurrence rates were significantly reduced after the installation versus the no installation group. And the median time to recurrence was substantially longer for the patients who were able to receive a post-operative chemotherapy dose. So I mentioned that they included multiple different agents in this meta-analysis, but if you look at the individual agents themselves, mitomycin C reduced the recurrence risk to about 42% and really had the most robust evidence to support it. And so I think most people were using mitomycin C before gemcitabine, which I'll talk about in a little bit. They found similar effects for epirubicin and purorubicin, but there was less robust evidence to support these drugs, and thiotepa didn't really appear to be particularly useful and have limited evidence of efficacy. So mitomycin C was the standard postoperative chemotherapy drug for quite a while. Now, these drugs really help most with recurrence. If you look at the risk of progression or death, there really weren't significant improvements for just single-dose postoperative chemotherapy. The primary effect of these agents is reducing the time and risk of recurrence, which I think is useful because we're really using these agents for low-risk disease, and most of these patients with low-risk disease aren't going to die from their bladder cancer, and most of them won't progress. So what we're really trying to do is just reduce the risk of recurrence. So more recently, we moved to using post-operative gemcitabine compared to mitomycin C. This was based on the SWOG 0337 trial. That was a randomized controlled trial at 23 US centers for patients who had a suspected low-grade non-muscle invasive bladder tumor without any history of high-grade disease or more than 2 low-grade recurrences in the prior 18 months. And the study tested gemcitabine versus saline alone. That was a little bit controversial why they didn't test against the mitomycin and gemcitabine, but the authors argued that the reason for saline was that most people in the country weren't giving post-operative mitomycin, and so they argued that saline was really the true standard of care at that time. And so they looked at their primary outcome was time to recurrence, and 406 patients were randomized, and they found significant improvements in recurrence-free survival among all patients and among patients with low-grade disease. And they found no differences comparing gemcitabine to saline alone in toxicity, progression, death, and recurrence rates among high-grade patients. So it seemed that gemcitabine was ideally used for patients with low-grade or intermediate risk disease after TURBT. And the nice thing about gemcitabine is it's really well tolerated. There's few adverse events, and it's relatively cheap. So pretty much in my practice, I'm only using post-op gemcitabine. So in summary, post-operative intravesical chemotherapy does decrease recurrence. It has some associated adverse events, mostly with other agents. Gemcitabine is usually pretty well tolerated. It hasn't been broadly adopted in the US. There are studies showing that it's not very well utilized, the immediate intravesical post-op chemotherapy. But there does appear to be improvements in recurrence, but no significant impact on progression or survival. But again, for these low-risk patients where we're using intravesical post-op chemotherapy, what we're really trying to do is just reduce their rate of recurrence. So when should we offer repeat TURBT? So repeat TURBT is recommended for a few situations by the AUA guidelines. It's recommended for an incomplete initial resection for high-risk disease. It's recommended for high-grade TA tumors within 6 weeks of the initial TURBT, or in a patient with T1 disease, particularly if there was no detrusor muscle present found in the initial specimen, because there is a concern about upgrading or upstaging these patients. And so repeat TURBT is recommended due to the fact that residual tumor and upstaging are found in a significant number of patients with high-grade TA or T1 disease. This systematic review included a heterogeneous group of studies, but it did demonstrate that repeat TURBT was shown to detect a significant amount of residual disease leading to upstaging in a significant number of patients. And also repeat TURBT was able to reduce recurrence and progression in some patients. Now, there was a randomized control trial evaluating repeat TURBT for T1 disease. And this study found that repeat TUR led to finding residual disease in about a third of patients, and 8% of patients were actually upstaged. And also the recurrence-free and progression-free survival were substantially improved in the repeat TURBT group. So in summary, for repeat TUR, it's an important component of non-muscle invasive disease management. Granted, this is based on a pretty heterogeneous group of data. Regardless, the studies consistently have demonstrated a significant amount of residual tumor. Also, upstaging of T1 high-grade disease occurs in a significant number of patients, up to about a third of patients. Also, there doesn't appear to be significant evidence of improvement in recurrence and progression, or it does appear to be improve recurrence and progression, and it may even improve cancer-specific survival, depending on the study that you're looking at. So now moving to our discussion of adjuvant intravesical chemotherapy and sort of a risk-based approach. So following diagnosis, for low-risk patients, the AUA recommends not giving patients induction intravesical therapy. There is very little evidence to suggest that patients require induction therapy due to their pretty good outcomes overall. Obviously, we talked about immediate post-operative therapy should be given as a way to reduce recurrence, but not giving any additional therapy beyond this. Now, for high-risk disease such as CIS, T1 high grade, high-risk TA disease, BCG administration should be given for a 6-week induction course. If there is response to the induction therapy, then a maintenance course should be continued for up to 3 years. A meta-analysis done in 2001 evaluated 6 trials comparing BCG to TUR alone, and the recurrence rate was significantly reduced at 12 months with a hazard ratio of 0.44. And one important component of BCG therapy is not only giving induction, but also giving maintenance therapy. And the benefit of BCG in reducing progression appears to be mainly derived from the use of maintenance therapy compared to using induction therapy alone. And this randomized trial was one of the first to evaluate maintenance therapy, and it looked at 550 patients who had high-risk disease and completed induction therapy. And they were randomized to maintenance or no maintenance therapy. And the primary endpoint was recurrence. And the maintenance schedule consisted of 3 months, 6 months, and then every 6 months for 3 years. And this study demonstrated significant improvements in recurrence and progression. Now, question is, do you really need to give all 3 years of maintenance therapy? Another randomized trial was designed to test if you could give a reduced dose of BCG, and they reduced it in different ways. They tried by reducing the dose of BCG as a 1/3 dose, or if you could reduce the time from 1 year to versus 3 years. And they were testing the hypothesis if giving a reduced dose, either 1/3 or 1 year of maintenance, would be non-inferior to giving a full dose for either 1 or 3 years. And this study is useful because it used modern BCG therapy using the Tice strain, and they included patients with high-grade T1, recurrent T1, TA high-grade, but they didn't include any CIS patients. And the primary endpoint was recurrence-free survival, but they also had predefined exploratory analyses looking at progression and overall survival. The study does have limitations. One limitation is that only about 1/3 of patients completed the full 3 years of maintenance therapy if they were assigned to that group. But ultimately, the study was unable to reject the hypothesis of non-inferiority of either the 1/3 dose or the 1 year of therapy. They found that particularly in higher-risk patients, 3-year full-dose maintenance therapy reduced recurrences significantly. And they didn't find any significant improvements in progression or survival. So the final recommendations based on this trial were as follows. So for intermediate risk disease, you should consider 1 year of full-dose BCG therapy. And for high-risk disease, you should consider 3 years of full-dose BCG based on their improvements of recurrence risk. And as I mentioned, they didn't see any improvements in progression or overall survival for high-risk patients, but the trial wasn't specifically designed to look at that. And again, it was designed as a non-inferiority, not a superiority trial. So moving to intermediate risk. So this is a heterogeneous category. The AUA guidelines recommend the following. Clinicians should consider 6 weeks of induction, either chemotherapy or BCG, compared to high risk where they only recommend BCG. And if patients have a response to either induction, chemotherapy, or BCG therapy, then they should move on to maintenance therapy for 1 year. And that year duration was based on the EORTC trial that I just talked about. So due to the heterogeneity of the patients within the intermediate risk group, some have advocated for a more risk-based approach within the intermediate risk category. So it's like a risk stratification within a risk stratification. And they stratified the intermediate risk group by the following factors: having multiple tumors, having a tumor greater than 3 centimeters, having recurrence within 1 year, or having frequent recurrences, such as more than 1 recurrence per year. So for patients with 0 of the above risk factors, then you would treat them like a low-risk patient and not give them any induction therapy. If they have 1 to 2 risk factors, then you would treat them like an intermediate risk patient and give them induction in 1 year of maintenance. And lastly, if they had multiple risk factors greater than or equal to 3, then you would treat them as really a high-risk patient and give them induction and maintenance BCG therapy. So what do we do for BCG unresponsive disease? Well, there's a newer regimen that I prefer in my practice, which is a combination of gemcitabine and docetaxel. An initial study of 276 patients with recurrent high-risk disease and prior BCG treatment were treated with gemcitabine followed by sequential docetaxel. Overall, they found minimal side effects and fairly good outcomes with a 2-year recurrence-free survival of 46% and a high-grade recurrence-free survival of 52%, which is pretty good in this, previously treated BCG unresponsive disease. And these patients can be pretty refractory to treatment and tend to recur. So these 2-year outcomes looked pretty good. Granted, this is a retrospective series and had a fairly heterogeneous group of patients. Another newer agent that seems to be coming down the pipeline is nadofaragene firadenovec. It's also known as Instillidrin. This is an intravesical therapy where an adenovirus is instilled into the bladder, and that delivers interferon alpha 2b into the bladder epithelium, and it's designed to stimulate an immune response. And a single-arm phase 3 trial was performed for BCG unresponsive high-risk disease, and the drug was given intravesically at 1, 3, 6, and 9 months. 151 patients were included in the final analysis. 53% of CIS patients had a complete response at 3 months, which was maintained in about half of those patients at 12 months. And 72% of high-grade TA or T1 patients had a complete response at 3 months and was maintained in over half of the patients at 12 months. So overall, based on this data, it appeared to be a promising new intravesical therapy and maybe something that we see in the coming years as something that we'll be incorporating, but it's not currently being used. What about cystectomy, immediate cystectomy for non-muscle invasive disease? There are fairly limited indications, but important indications for upfront cystectomy for non-muscle invasive disease. Obviously, these patients need to be fit enough to undergo surgery, and the patients that appear to be particularly good candidates tend to have high volume T1 disease or have persistent T1 disease on repeat resection, or they have T1 disease with CIS, LVI, or variant histologies, and that's because risk factors for upstaging at time of cystectomy include CIS, lymphovascular invasion, variant histologies, and high-grade disease. So if you have a pretty healthy patient who has fairly high volume T1 disease or has other risk factors, particularly some of the more aggressive variant histologies, immediate cystectomy is something that should be considered and offered to these patients. So moving on to our risk stratified follow-up for patients with non-muscle invasive disease. We need to monitor these patients for recurrence, not only in the bladder, but also in the upper tract, depending on their risk stratification. Patients at highest risk for developing upper tract urothelial carcinoma are the patients with intravesical recurrences, non-papillary tumors, and patients with high-risk disease. Unfortunately, CT urogram isn't very good at detecting upper tract disease. It detects only about 30% of upper tract disease, and cytology is also not great at detecting upper tract disease. It's about 7% in a systematic review of 57 different studies looking at upper tract recurrence. So, we don't have great tools at detecting it, but those are the kind of the best things that we have. So for patients with low-risk disease, they should have a surveillance cystoscopy within 6 to 9 months after their initial TURBT and then annually after. At 5 years, you can discuss with the patient about continued surveillance. I'll often discuss with the patient and move to maybe like a biannual cystoscopy. But after 5 years, you can have sort of a risk-based approach and also a discussion with the patient if you want to continue cystoscopy. If you do detect a recurrence in a patient with low-risk disease, you can consider an office fulguration if it's small and it's an elderly patient and it appears to be another low-risk recurrence. Otherwise, you need to take them back for obviously another TURBT and then risk stratify the patient again based on the new pathology from your recurrence. For intermediate risk disease, the AUA recommends, and what I practice is a cystoscopy and cytology every 3 to 6 months for the first 2 years, then every 6 to 12 months for the next 2 years, and annually after that. And for high-risk disease, cystoscopy and cytology even more frequently. I usually do every 3 months for the first 2 years, and then every 6 months after that. And both intermediate and high-risk patients should undergo upper tract surveillance imaging for at least every 1 to 2 year intervals because of the risk of upper tract recurrence being higher in these patients. Now, as I mentioned, one of our goals for surveillance is monitoring the upper tract for urothelial carcinoma. And I have the sensitivity and specificity for a number of different markers listed here. You can see the sensitivity and specificity for cytology is pretty poor. Other markers like FISH have a wide range of sensitivity and specificities depending on the study you look at, but possibly maybe better than cytology, but it is more expensive and not something that we routinely use. CT and MRI urography have pretty good sensitivity and specificity, particularly CT urogram with a sensitivity of 96% and a specificity of 99%, which is why this is the imaging modality that we'll typically use for detecting upper tract disease. But in patients who have, reduced renal function, obviously you can't use IV contrast as readily. So MR urography is a potential other adjunct surveillance strategy. So that kind of brings me to the conclusion of the talk. In summary, for non-muscle invasive disease, complete staging and resection is critical. To improve this, it's important that you use a standardized way of performing and documenting your TURBT. Also, adding enhanced cystoscopy like blue light may improve your TURBT in certain instances. Risk stratification is obviously very important, but there's room for improvement for us to better stratify these patients and do more research to determine which patients are best suited for certain therapies. Low-risk tumors should be given immediate post-op dose of chemotherapy. High-risk disease should be given BCG induction and up to 3 years of maintenance. And intermediate risk disease can consider 1 year of BCG or chemotherapy. And then upfront cystectomy, as I mentioned, should be considered for high-volume T1 high-grade disease with other risk factors. As we move to the future, outcomes should combine modern risk stratifications. We are working on molecular classifications and also incorporating studies that use enhanced TUR and modern BCG therapy will improve our ability to risk stratify these patients. We also need to continue to produce more concise and generalizable studies to allow for easy adoption of our findings. As you could see from the data, it's a very heterogeneous group of patients. So it can be difficult to really compare different studies. We also need to improve our understanding of who's an ideal candidate for upfront cystectomy, who's overtreated, and how can we individualize intravesical therapy regimens. And so as we move to the future, this is kind of what I envision or what I think is going to be happening is more of this multi-omic analysis of non-muscle invasive disease. So right now, we're mostly looking at things like stage, grade, but as we understand non-muscle invasive disease, we'll move to things like including genomic alterations in the tumor. Also looking at the tumor immune microenvironment will be important. And this will give us more of an individualized approach to how we treat these patients. Certain patients may respond better to BCG. Certain patients may respond fine to surveillance alone with just TUR. So including all these other omics, proteomics, genomics, and looking at the tumor immune microenvironment, this is the way that non-muscle invasive disease is moving. And this is what we'll probably see in the future. So thank you.
Thanks, Dr. Shapiro. on the edge of my seat the entire talk. So
Good.
wonderful, wonderful stuff. I'm glad you brought up the Instillagrin trial. We were part of that trial here,
Yeah.
and I enrolled 2 patients. They both did not respond. So that was my anecdotal experience. But the data was published in JCO, and I think they're going through the regulatory process of getting that drug approved. So I think it will be coming down the pike. The nice thing for urologists is it's an intravesical agent, so we can manage it. The downside is it's an adenoviral vector, so it's a little bit messy, I think, from a pharmaceutical standpoint to handle. So we'll see where that goes. Mike, I guess I wrote down some notes. I'm trying to think oh yeah, I was going to ask, can you talk a little bit, you had a few slides on repeat TURBT, and I know there's some nuance though to who you recommend a repeat TURBT on, or who we recommend. Can you just talk a little bit about, who do you think really needs it, and is it something that we should do for every patient, or how do you sort of sort through that in your practice?
Yeah, so I think repeat TUR is very important, obviously, as I mentioned, based on the trials and the studies. But essentially for repeat TUR in my practice, I recommend it obviously for anyone where I didn't think I could get all of the tumor out at the initial TURBT. Sometimes you are dealing with large tumors where you aren't able to successfully get all of the tumor out, but maybe they aren't. The question there is, if it's a very large tumor, should you just take them to immediate cystectomy? Some of these patients may not be healthy enough to get a cystectomy, but can tolerate a TURBT. In that situation, I'll take them back. I would say that's a pretty rare situation though, because we're pretty aggressive about getting all the tumor out at the initial TUR. So obviously, if you think you left tumor behind, you need to go back and get it out. Secondly, if it's a high-risk disease and you didn't get detrusor in the specimen, you need to take them back to do a second look, because if they have muscle-invasive disease, obviously that completely changes how you're going to treat that patient. So patients with high-grade lesions or T1 disease, those patients need to be taken back if they don't have muscle. Also, if they have high-grade disease, oftentimes I will take them back, even if it's high-grade TA, because in those patients, I am still concerned about risk of stage progression, because sometimes those tumors can have muscle-invasive disease based on some of the studies. So I think high-grade disease and also T1 with no detrusor, all those patients, I think second look TURBT is important.
I'll just add, I agree with all of what you've said. I think the intent of the repeat is to, make sure that you got it all the first time, and to make sure that it's not worse than you thought it was. So the only, subtlety for me is when I'm seeing these patients back every 3 months for their cystoscopies and they have a recurrence, I usually don't do repeat TURBT at the time of a recurrence. I think most of the intent is at the time of the initial diagnosis.
Yep. Yeah, that's
so, because at the time, if you're scoping somebody every 3 months and they have a recurrence, it's unlikely that they've progressed to muscle invasive disease at that point in time. So I think I think for the residents, especially at the VA and whatnot, I think we don't have to, if it's at the time of a recurrence, you don't necessarily need to do a repeat TURBT. You should say, well, we should try something other than BCG, or maybe they need a cystectomy, but you don't necessarily need to do repeat TURBT at the time of a recurrence.
Yeah,
Following them closely.
Yeah, that's a great point. Yeah, I was talking in the initial diagnostic setting, so.
That gets confusing sometimes because in the guidelines, it doesn't really spell that out. So thanks.
I think it's interesting in that situation though, if you had a progression. So let's say you initially had like a high-grade TA lesion, your recurrence is high-grade T1, then I may think about it a little bit about doing a repeat TUR, because now you've just progressed in your stage a little bit. So I think in those situations, it's a little different.
I think that's totally fair. Yeah.
Yeah.
Same question. So yeah, thanks, Dan, for that. Yeah, I agree with Kyle's assessment of Instilligin. I mean, it was sort of a bit underwhelming, the 45%, and that's a selected single arm trial. So it was not a home run. So specifically, how are you managing those patients right now? So CIS recurrence, say 6 months after getting their induction BCG.
Yeah, it's a difficult situation. It often depends on a lot of patient factors. So if you're having immediate recurrences, like within 6 months, they got appropriate BCG therapy, you need to discuss with them about cystectomy versus you also could consider, reinduction BCG, but it depends on how quickly they recurred after their BCG therapy. So I think for these patients, I will talk about, let's say if they had high-grade T1 disease and they recur immediately after BCG therapy, then I'm talking more about upfront cystectomy, or I guess it wouldn't be upfront, but cystectomy for non-muscle invasive disease. You can offer them repeat induction BCG therapy if they have a later recurrence. So if they recur, let's say they get appropriate induction and they get a few rounds of maintenance therapy and then they recur, then I'll consider, doing repeat induction BCG therapy, or you could consider giving them, I like to use gemcitabine and docetaxel. I think that seems to be a pretty effective regimen and it's usually well tolerated. So I think that's typically how I manage it. And it depends a lot on how fit the patient is, how well I think they could tolerate a cystectomy. But, when you're dealing with these patients that are recurring frequently, you're giving them all these intravesical therapies. I think we don't use cystectomy. I mean, we do cystectomy a lot here, but I think you need to be more aggressive about trying to get their bladder out because they will progress. And I see a lot of these devastated bladders that have been treated with like every intravesical therapy, and now they're like 86 years old. And 10 years ago, we probably could have gotten their bladder out and they'd be a much better surgical candidate than they are now. So I think it's important to try and be a little bit more aggressive about getting the bladder out earlier rather than later.
Yeah, that sounds like a very reasonable approach. I mean, that's the appropriate control arm for the Instilligin is either, gemcitabine, docetaxel, or repeat BCG, and that's what they should have done for that trial. But unfortunately, that was sort of one of those ones that we expected a lot more that it was not. And you did that trial, correct, Kyle? Instilligin?
We were part of it.
Yeah.
Tracy when he was here was the PI, but I enrolled several of my patients.
Right. How'd they tolerate that?
They tolerated it fine. It's just their cancer. I think one of the patients we wound up doing a cystectomy on, and the other patient actually salvaged with valrubicin, a throwback. So she failed Instilligin and then was not really a cystectomy candidate, and we salvaged her with valrubicin. But the issue with the BCG non-responder, BCG refractory patients, is these trials are hard to accrue. And so having a control arm has been very challenging. And if you look at for instance, the pembrolizumab, which was approved also for BCG non-responders, it was approved off of 100 patients in a phase 2 trial. So the FDA has sort of relaxed its requirements for approval because this is a space where we don't have very good treatments. And we have a trial right now. It's the Theralase trial, photodynamic therapy. So that's something that, we just enrolled our 7th patient. So these patients are out there. And it's for patients, like Dan said, that refuse cystectomy or are not candidates.
Dan, I have a question for you. First of all, thanks for that presentation. Very thorough, very easy to follow. So thanks for putting that together. Question is following up on a comment that you made about the intravesical chemotherapy immediately after TURBT, that in North America, it's been kind of slow to be adopted. So if it's the right thing to do, obviously we here locally, we can't control what's going on at other institutions, but do we have any kind of processes or structures set up for helping to ensure that, with an initial TURBT that, using our, whether it's our EMR or from a scheduling perspective, that that the OR kind of knows that, hey, this is a new TURBT, we should be doing some intravesical chemo, or is it just surgeon dependent?
Yeah, I think I don't think we have any like standardized process for ensuring that post-op intravesical chemotherapy is used. I do think it depends on the provider. A lot of times we will hold off on giving intravesical therapy immediately post-op for a couple of reasons. If we don't think that, or if we think that we may have a small perforation in the bladder, you can't give intravesical chemotherapy. Also, if you're concerned that maybe this is a more high-risk lesion, you won't give intravesical chemotherapy. Those are some of the bigger reasons why we wouldn't give it. But yeah, I mean, I can't speak to totally why it's not being used more frequently around the country. I think a lot of it has to do with time, money, and just remembering to do it. It's can be annoying if you did, let's say in your pre-op you forgot to order it and then waiting for pharmacy, but I think it's important. So, if you think it's a low-grade lesion, you're doing your initial TURBT, or if it's a subsequent low-grade recurrence, I think it's important to utilize. So I routinely do it. It's pretty easy. The pharmacy can mix up gemcitabine pretty quickly. So
Yeah, I think our numbers are probably better than they are nationally,
Yeah.
I'd say. But not every patient's a good candidate for it.
Yeah.
Also, it's not a home run. So as far as, it doesn't reduce progression or deaths, but these patients aren't going to, like you said, die from their bladder cancer anyways. So I think that's some of the challenges, is just people buying into the data and saying, well, is it really worth the extra work to order it, to wait for pharmacy to make it? But we use it fairly regularly here.
Yeah.
Another question about your omics slide. So I think that, just to use the current buzzword, personalized medicine, right? And that's where a lot of everything that we do is going, the individualized patient phenotype and how to apply the treatments to that individual phenotype. How close are we here at our institution to getting some of those omics? Meaning that if you tomorrow do a TURBT, do you have somewhere, if you wanted to send the tissue for those omics, or are we not that close yet here?
Yeah, you certainly can send any tumor tissue for mutational profiling, and oftentimes we'll do that. We tend to do it more in the metastatic setting to look for, to stratify, what type of chemotherapy or immunotherapy we should get. In terms of using it on a day-to-day basis for non-muscle invasive disease, I think it's pretty rare that we would look at the mutational profile, because we don't really have targeted therapies that are, very robust or approved for non-muscle invasive disease. So we're still a far way off from using that clinically in our day-to-day practice, but you can send tumor tissue for mutational profiling and look at things like PD-L1 status. So
the FGFR mutation is for a drug called erdafitinib, and it's being used for metastatic patients. There was a clinical trial for non-muscle invasive patients that we were looking at, where at entry they would send off the tissue, and you had to have that mutation to be eligible for the trial with erdafitinib. So they're looking at it. We're getting there, I think. And same thing with the PD-L1. I think Borza asked about pembrolizumab. So we'll send PD-L1, but usually in the metastatic setting, it may not actually matter though if they express that. And interestingly, patients still have shown a response to pembrolizumab even if they aren't expressing that. So there's a lot that we're learning, and the field is moving fast. I like that slide too, Dan. That was pretty exciting.
All right, should we overtime?
Great. Thank you very much, Dr. Shapiro.
All right, thanks.
Why don't we take 5 to regroup for unknown conference and reconvene?